Hello, I am Dr. J. Maheshwari, knee and shoulder specialist in New Delhi. Today we are going to talk about a very important surgery in shoulder called rotator cuff repair. Now I am going to give you some tips and pearls that I have learned over more than 2 decades of practicing this surgery. First is position. There are 2 positions used for shoulder arthroscopy. One is lateral position, one is sitting position. There are a number of surgeons all over the world who are comfortable doing all shoulder arthroscopy in either lateral or sitting position. When I started doing arthroscopy of the shoulder, it used to be mostly instability surgery where lateral position was my favorite position. Then I started doing arthroscopic rotator cuff repair using the same lateral position. But I realized when you work in the lateral position and you are doing rotator cuff repair, you have to put your hands like this, and it used to tire my hand. After a couple of cases, I used to feel it's straining my own shoulder. Then I switched to sitting position. Now in sitting position, your hands are comfortable and it is advantages, and I'll tell you what are the advantages of doing rotator cuff repair in sitting position. Advantages are, first of all, your shoulder is free, you can move it anywhere. You can do full internal rotation, external rotation, abduction. So depending on which part of the shoulder you want to see, you can rotate it. It's a very big advantage which is not there in a lateral position when the arm is in traction. Then you can see how comfortable my own shoulder is. I am not abducting, I am working here and both my shoulders are in nice comfortable position and there is no strain on the shoulder. And third is you can always use a arm support. If you are fixing a position in which you are operating, you can fix a arm support and then you don't need the assistant. There are disadvantages of sitting position. First disadvantage is you need a special table. Either your table, OT table has to be heavy attachment for shoulder arthroscopy, or you can make some simple chair like this and tie it to the main table and you can do shoulder arthroscopy. But sitting position is very difficult in conventional OT tables. Another disadvantage is not many anesthetists are comfortable giving anesthesia when the patient is sitting, particularly if you demand hypertension. So these are the 2 major disadvantages why sitting position is not that popular yet. Now there are some changes I have made in my technique over the years, and let me tell you through this video what are those changes. Change number 1, no longer do I do a routine glenohumeral arthroscopy in cases of rotator cuff tear. Why? Because today when I do a surgery on a rotator cuff tear, I have already done MRI. And MRI shows me all the possible pathologies inside, and more often than not there is no intra-articular pathology except rotator cuff tear, and so I am quite focused on going straight to subacromial space. I do not waste maybe 5-7 minutes going to the glenohumeral joint and then coming back to the subacromial space. I go straight to subacromial space. So my primary viewing portal, what is called first portal, is posterolateral here. This is the acromion, and I divide the acromion in 3 parts, and the lateral bottoms. This is somewhere where my viewing portal goes, just under the lateral border of the acromion in this part, posterior part. I call it posterolateral portal. Now this is my main viewing portal, but I do make difference between where the viewing portal is going to be depending upon the tear itself. So if the tear is less than 1 centimeter, in such a case, I do glenohumeral arthroscopy first. Why? Because sometimes you can't see that small tear directly from the subacromial space. More often than not, the tear is better visible from below, from the undersurface. And you may need to pass a PDS suture to identify this tear from outside. So when you are seeing from inside, you can see the tear, you pass a needle, pass a PDS suture. That suture will guide you when you are looking into the subacromial space where the tear is. Otherwise, sometimes it is very difficult. And also you can do biceps sternotomy from inside. In a small tear, you cannot do biceps tenotomy from outside because you can't go into the joint through those small tears. If the tear is 1 to 3 centimeter in size, I go straight to subacromial space. I don't go to glenohumeral. I do a biceps tenotomy from the subacromial space only. You can see it. You can go through the tear and you can see inside of the joint. You can even examine the cartilage of the glenoid, cartilage of the head of the humerus, even subscapularis. So everything you can see through the tear. You push your scope through the tear and examine inside of the joint. So there is no need to make a separate glenohumeral portal. If the tear is more than 3 centimeter, again go straight to the subacromial space. Biceps may be preserved. If the tear is big in size, I don't do a biceps tenotomy straight away. I keep it for future. I make an assessment whether my tear is repairable. If not, then I use biceps as a SCR. So this is the difference I make in my first viewing portal based on the size of the tear. Now this is how I make my first viewing portal. The viewing portal, posterolateral portal. Just under the acromion, I make a small cut, introduce my cannula, and I touch the lateral part of the acromion, and then just slide the cannula under the acromion, and I can feel the tip of the, with the tip of the cannula, I can feel inside that I am touching the subacromial space, and you can straight away see the synovium and everything in the subacromial space. The first portal is straight to the subacromial area. The second change I have made over the years is I make all subsequent portals are intentional. So there is no fixed rule where my second, third, fourth portal is going to be. It is all guided by where my tear is. For example, and all these are customized to need. It is based on what I need. For example, working portal. There is no fixed area of working portal. If my viewing portal is here, I have a wide area from where I can put my working portal depending on the tear. And I'll show you how I do it. Now, I make another good portal, what I call grasper portal or utility portal. And I'll again tell you what it means. Then I make a suture retrieving portal and anchor insertion. All these portals do not have a fixed landmark. They are made based on where I want my instruments to go. And I'll show you all these subsequently. So let's talk about the working portal. Now, so I'm seeing from the posterolateral portal, and then I introduce a needle and I see where my needle is going nicely towards the cuff. And if I'm satisfied that the direction of the needle, the up and down of the needle, and the needle is approachable to all parts of the tear, then I make a small cut and introduce a straight artery forceps to dilate it. And with the artery forceps itself, I can see that I can reach to different parts of the tear. So the advantage of making such intentional portals is every time you introduce the instrument, it goes exactly where you want it to go, because the portal is designed like that. Next change number 3 I made is I make a special grasper portal. Now this is a portal which helps you in handling the tissues inside very well. So you make one viewing portal, then working portal, and another small portal by which you can hold the tissues while you are working through the working portal. And I'll tell you how it works very well. So this is the way you make a grasper portal. You feel the right place, you introduce a needle, and you can see that the needle should be able to reach the tissue. And then you make a cut there and a small cut, maybe because you are only introducing 4 millimeter grasper, it's not a big cut, and you introduce the grasper through it, and then you can hold the tissues. So my working portal is still free to introduce my instrument, and grasper is helping me to hold the tissue while I introduce instruments through the working portal. So this grasper portal helps me in two-hand working. With one hand I am holding the tissue, with the other hand through the working portal I am introducing the instruments. So it gives me the real feel of surgery which we normally do with two hands. Now change number 4 I have made is cleaning, and cleaning is a very important aspect of rotator cuff tear because there is a lot of synovitis, and if you don't spend good time in cleaning during the procedure, everything swells up and your visibility becomes very, very poor. I do this cleaning in 2 steps. Step number 1, I see from the posterolateral portal and introduce my shaver from the working portal. So viewing from the posterolateral, putting shaver from the working portal. And what we do is then all the anterior tissue, which I can see very well, remove them. You can go all the way medial also with a shaver or RF, and also to some extent you can go even posteriorly. But posterolateral is not so easy to approach from this area. So that is step number 1. Use a shaver, use a RF and clean up the area on the anterior side, on the medial side, and also to some extent the posterior side. So this is part 1 of the cleaning process. After that, what I do is I switch. So I put a switching stick in my working portal, take the scope out, take the scope into the working portal. So I am seeing from here, and then I introduce I am seeing from the working portal, I introduce my RF or shaver from the previous portal, which was viewing portal, and I remove all the fringes of tissue, the synovium from around the viewing portal. See, all these frills during surgery come in front of my lens. So it is a good idea to clean up this area and remove all these fringes, so that while you are doing surgery for next a few minutes, these tissues should not fall in front of your lens and thus obstruct your visibility. So this is an important part of the cleaning, because then you don't want the trouble of these things coming in front of your lens all the time. Now come the important aspect of planning of cuff repair. Step number 1 is you have to define the shape of the tear, and we are all aware there are 3 types of tears. One is crescent, small, 1 or 2 centimeter mostly. Then we have a narrow tears, which is either V or long U, and they are narrow tears. Their footprint here is smaller, but their length is more. And then you have a large crescent shaped tear, which are of various shapes and sizes. These are the 3 basic tears you see. And if you identify the shape of the tear, you can plan your surgery. And I'll tell you how it is done. So let us say, once you know the type of tear, shape of the tear, you see reducibility. Whether we can get the tear back to place, you may have to do some releases. You have to see whether the tear has lamination. But both these aspects are important when you are trying to repair. So shape, reducibility and lamination, these important things have to be noted before you actually start repairing. And you have to make a mental plan of how to repair. You must know where will go which part of the tear. So you have to basically mix the rotator cuff to GT, and you must know which part of the rotator cuff will go to which part of the GT. For example, if there is a small crescent tear, it's very simple. You can just bring it laterally, put 1 or 2 anchor, and it sits very nicely. You may have a V or Y tear or a long U-shaped tear. You can do margin conversion. It becomes a small crescent. You can fix the crescent back to GT. Exactly like that. These are simpler tear patterns, but more complex is what I call large crescent looking tears. They look very huge, and if you try to bring this part here, it is not possible. So now you have to find out what is this tear in reality, and I have realized that all these big large crescent tears are not actually crescent tears, they are L or reverse L. And let me explain this to you. So I divide my large crescent tear into 3 parts, about 30%, another 30% and another 30%. These 2 points between 30 and 60 and 30 and 60, these I call D points. So I call them D points because you cast them and try to see whether you can bring this tissue here or you can bring this tissue here. For example, you may hold the D point here and bring it, and you will find suddenly the whole margin of the tear, this margin, the pink margin, sits very nicely on the GT. So this is a reverse L tear, which was looking like crescent, but it was reverse L, As soon as you identified the deep point and pulled it here, the tear sat down very nicely. Similarly, it can be reverse of this, that you hold this part and bring it here, and this blue part of the tear sits nicely on the GT and it becomes L-shaped tear. So actually all crescent tears are mostly either L or reverse L. It takes a little while to understand, and then you can plan your surgery accordingly. D point is important to identify. Now I call it preparing bride and groom. So because you have to mix two things, you have to get the healing between the GT and the rotator cuff. So unless you prepare both of them nicely, the biology is not there, the healing will not happen. So what do? You have to first prepare the cuff. So remove 1 centimeter of the bursa from the cuff, because that makes it easy to catch your threads. All the frills, loose tissues have to be removed. Debride tendon margins, if they are dead or they are very sclerotic, particularly from the undersurface. Identify lamination. This is preparing the cuff part of it. Then you go to preparing the GT part of it. For GT, you have to create a nice healthy bleeding surface, which is done in 3 parts. First is you take a RF, because to remove soft tissue from the GT with any other instrument is difficult. So use RF and burn away all the tough tissue, soft tissue. Now once you have removed the soft tissue, you can see there is only bone there. Now this bone is not healthy because you used RF, and RF does some damage to the vascularity. So next part is to use a burr, and use a burr in a light mode, don't press too much, and just remove a little bit of a top surface of the GT. And you have to be very careful about doing this, because you can't afford to remove good subchondral bone, because that will weaken the hold of the anchor. So after doing this, then I do a fine tuning, and with the help of a rasp also. So 3 steps: RF, burr, shaver and rasp. I also do tuberoplasty to make it better. Now the other intentional portal I make is, why I call it intentional, because every portal is made with some aim. So I make an intentional portal called suture retrieving portal. So once we are ready to start repair, from behind I go and put a needle and see, if I make a portal there, I want my instruments to come directly where I am working. So needle will tell me that this is the place and this is the direction, and if you go directly, you reach there. So you don't have to find your instrument during surgery. So every time you introduce the instrument, it goes exactly there. So that's why I call it intentional portal. They are made with clear purpose. That every time I take a bite, I want to retrieve the suture, I put the instrument, should go straight there and pull it up. For example, see this case. Here I did a glenohumeral arthroscopy first, and I used the cannula in the same portal to retrieve my sutures from the subacromial space. But as you can see, it hits directly the posterior part of the GT, and I have to manipulate my instrument to go to the surface where I want to catch the threads. So every time I have to put the instrument, it hits the back of the GT, I have to manipulate it and come at the top, which does not happen if you make an intentional portal, but there the instrument go directly where you want to go. Now change number 5, and this is another very important concept I have understood. When you are repairing GT to the, this is another important concept I have identified. When you are repairing cuff to GT, you must know exactly which part of the cuff wants to sit where, and you have to mark it. So let me show you how I do it. So I hold the tissue at the D point, for example that's the D point, I pull it and I can see how nicely the cuff is sitting at the GT, and now I mark on the GT, I mark where my anchor is going to be, and I gently mark on the synovium on top of the cuff, so that I know this part of the cuff should sit here. So I make a anchor here, and I know. Similarly, again second anchor, I make a mark, and then a very gentle mark on the cuff. And beware, you can't damage the cuff by trying to make this mark very rudely. So when I repair, I know this part will sit there, this part will sit there. And then we start our repair. You insert the anchor the way we normally do, and once the anchor is inserted where it was supposed to be, then you take the corresponding part. For example, here there is an anchor here and there is a corresponding part. You take the bite through that, so there is no tension on the repair. You are bringing the tissue where exactly it belongs by making these marks. Now you can use multiple suture passes, and initially you should have all of them. I usually find these bird beak kind of instruments very handy to come from the posterior side, in posterior part of the repair. These used to be my favorite instruments in earlier years, but I don't use them much now. Today the workhorse is self-holding, self-retrieving suture passers like these, which work almost everywhere. So take home messages. Use posterolateral portal as a first entry portal. In my opinion, don't waste time beating around the bush, going into the glenohumeral joint, and that posterior portal that you have used for glenohumeral joint is not very handy to use in the suprahumeral space when you are trying to retrieve the sutures, as I have already explained. Make all other portals what I call intentional portals as per the need, starting from working portal to grasper portal to even suture retrieving portal. And grasper portal gives you handiness by two-hand working. Two-step cleaning, because you must clean the area where your scope is going to come, otherwise all those frills disturb you. And then your planning repair. Understand the anatomy of the tear, which means shape of the tear. Tear and anchor have to be matched for tension-free repair. Use multiple suture passing devices, whichever is handy to you. And do not cut away the biceps right in the beginning, particularly in large tears. Thank you very much. I hope the video is useful.